Facebook and YouTube at CAC TV Kenya. We featured breast cancer survivors and they shared their journey, and you can find some time to find that episode there. And in regards to your comments and questions on our social media pages, we are very glad to be joined by a breast surgical oncologist to answer all those questions that you had while you are watching that episode. My name is Aida Muzati, and as I said, I'm being joined by Dr. Mutebi, who is an oncologist from the Aga Khan Hospital. Thank you very much, Dr. for finding time to join us on Health Nuggets tonight.
Thank you for having me, Aida. Happy to be here.
Thank you.
Yeah.
Well, first of all, let's talk of this month's theme, giving hope and saving life. What do you have to say about that?
I would say it's very relevant because I would say I'm in the hope business. And I think, I don't even say I'm a doctor, I say I'm in the hope business. And I think it's important to give hope because I think what has happened for the longest time, especially in sub-Saharan Africa and in Kenya as well, the narrative has been that cancer equals death. And what we're saying and what we're trying to shift the narrative around that is to let patients know that irrespective of the stage of the cancer that you have, it is treatable.
Yeah. Okay, now going to our topic of discussion, breast cancer. Yeah. Let us look at how breast cancer comes about from a medical perspective.
So Aida, I would say what's happening is, I would say that it's a simple question, but also a very complex one, because nobody quite knows what causes cancers. But if we think about it, what usually happens is that even as we're sitting here, we're all producing abnormal cells, but the body is removing these abnormal cells as we speak. Now, what tends to happen is that normal cells are just like us. You know, they're young, they get into teenage, they stress their parents, they become a little older, become useful members of society, and then they, sort of do a lot of work, become productive, and then they become a little older and they're told, hey, Baba, thank you for the services, please get retired. And that's a normal cell cycle. Now, what happens with the cancer cell is that the cancer cell has escaped the normal control mechanisms of the body. So instead of now, being retired gracefully, it just continues to divide. It becomes what we call immortal. So it keeps dividing and dividing and dividing and dividing and dividing. And so with that, you begin to see where the problem is. Because it keeps dividing without any controls or breaks, then it starts to take over areas that it's not supposed to. For instance, if it's in the breast, then you may start to feel a lump because now it's growing and growing and it doesn't really have any sort of breaks or checks to it. And then because you can think of it almost like a squatter, it starts to look for different areas where it can also go and continue to do the same bad behavior, as it were. But nobody quite knows between two people why this person sort of had that switch and why somebody else didn't. That question is still under investigation by not just locally, but global communities trying to figure out what causes that switch to cancers.
Even before we go to the statistics and the scope of how breast cancer is in Kenya and the world, I'm sure as we are talking of breast cancer, many people in their heads, maybe let me say they have a woman's figure in their head when you're talking of breast cancer. Let us talk of the fact that breast cancer is in men and women as well.
Yeah. So this is an interesting exercise because we say what we usually get asked sometimes is who can get breast cancer. And we say it's the mirror test. Look into the mirror, right? If you see exactly, it means we're all at risk. Now that risk may differ slightly, whereas women being female is already a risk factor, increases your risk of getting breast cancers. Men can also get breast cancers. It's not as common. It's maybe about, one would say, maybe anywhere between 1 to 3% of all breast cancers.
From your response, indeed, this year's theme, giving hope, falls into perspective.
Yes.
Okay, let us now look at the signs and symptoms. What are the telltale signs of breast cancer?
Okay, so the sometimes you may not even have any sign, and that is why we're saying it's important to go for screening, because sometimes you can have what we call a screen detected tumor, meaning that you're not feeling anything, but they do an investigation, usually a mammogram, which is an x-ray of the breast, and you're actually able to pick up the cancer. Other signs that you may be able to feel for yourself, for oneself, would be a breast lump, for instance, and usually the most common presentation of cancer, at least in our region, is a painless breast lump. Right. Now, it's important to sort of keep it in context, Ida, because 9 out of 10 lumps are not a cancer, right? But, you know, automatically everyone feels a lump and they start to panic and they're like, oh my God, you know, I have breast cancer. No, we're saying that, I mean, there's 9 other things that it could be, but and it does need to get, you know, seen by a, you know, healthcare provider, examined, and then investigated in order for us to know what exactly it is. Other signs can be things like you may not actually notice a lump, but you may notice, for instance, thickening of the skin. Sometimes you may get what you call an orange peel appearance, like it looks like dimpling of the skin. Sometimes you may, again, notice like a discharge from the breast. Again, not all discharges are necessarily a cancer, and you also do need to distinguish between what we call a secretion versus a discharge. A secretion is what you're checking for, a discharge is what comes out on its own. And usually what is of concern to us is discharges that are what you call spontaneous, meaning coming out on their own, and maybe unilateral, meaning just on the one side, and then also the nature of the discharge. Sometimes you may notice that it's blood stained or that kind of thing, and you know, you wake up and you find your bra or your, you know, night dress is stained. Those are the discharges that concern us. However, you can have what we call physiological discharges, where you have a clear discharge from both sides, and that sometimes can be seen in younger ladies. As you grow older as well, you may have what you call ectasia, which is a big fancy name just to say a widening of the duct that may cause a greenish or whatever discharge. But what we're saying is, again, it doesn't mean that it is a cancer, but it is important to get all discharges addressed, reviewed, and seen by a healthcare provider to see what exactly is going on and stuff. Other signs that you may see are maybe changes around the nipple, and we talk about an inverted nipple. Sometimes it's something that people are born with, like your nipples are inverted, or some people have what they call retractile nipples, where sometimes they're in and then sometimes they come out when it's a little warmer. But what we're talking about is maybe you've had your nipple looking one way, and then now it suddenly starts to change or gets pulled inward and that kind of thing. So those are the key one would say symptoms and signs that one should sort of look out for. Sometimes if you're putting your hands up, you may notice a pulling on the skin or just a general change in shape. And that would be something to watch out for. Sometimes it's just as subtle as an increase in size of the breast. Now, your two breasts are never exactly the same size. We always say, for reasons known to the left breast, in 70% of women, the left breast is slightly larger than the right. But what we're saying is an acute, and that's normal. They're never going to be the exact same size. But if you notice, for instance, there's a sudden increase in size in one of them, that's also would be a cause for alarm and stuff.
So it's very important to know your breast area.
Exactly, exactly. And what we talk about is breast awareness, and the idea behind breast awareness is being aware of changes and what's going on in your breast. And we talk about self-breast exam in the context of breast awareness. And so what we say is that in terms of the self-breast exam, I mean, simple tenets are 3. We just say look, move, and feel. And so looking involves, you know, just looking in the mirror, seeing any of the changes that we've observed, knowing essentially what your normal is, right? And then knowing that if there's anything that's, you know, differing from that, then that should at least trigger a health intervention. And then beyond looking, we say move. So we say you put your hands above your head, and usually you would expect both breasts to move up together. If sometimes you have a worrisome lump, you may notice that one side is moving up and the other side is staying down. So that's just something to watch out for. And then if you put your hands on your hips and just press forward, sometimes because that tightens the muscles over the chest wall, you may notice that there's some subtle lumps that are, now suddenly starting to bulge. And then the last bit we say is feel. And this sometimes you could do either lying down or in the shower. But the trick behind the feeling of the breast, because the breast tissue is very nodular. So if you feel with your tips, it always feels like there's lumps and bumps. Yeah. And then the other thing is that the breast tissue is I think the breast is one of the most dynamic organs in the body. It's changing from month to month, from period to period. And what tends to happen is, if you think about it, either the breast tissue is changing from mid-cycle to just before your period, the breast tissue is expanding. And if you think about it, either it's almost like having a cup, putting a sponge in it, and then adding water to the sponge. So the sponge is doing that, but the cup remains the same. And that is also usually the most common cause of breast pain or discomfort, especially around your period. And because the breast tissue is expanding and feels quite lumpy, then that's not really the ideal time to do it if you're going to do a self-breast exam. So we usually say if you want to do a self-breast exam, that the best time to do it is at least 1 or 2 weeks after your period, because by that time the sponge exactly, everything's back to normal. And then just because the breast tissue feels very nodular, then you want to use the pads of your 3 fingers, and what you're doing is you're just pressing down the breast tissue against the chest wall, because what tends to happen is that breast tissue, despite it feeling nodular or lumpy, bumpy when you touch it, is very compressible. It's like a sponge. So when you press down, the breast tissue goes down. But if there is a lump, because it's a different consistency, then it stays up when the rest of the breast tissue is going down. And that's how you may be able to tell that this is not, because sometimes you're wondering, is this normal tissue? Is this, a lump? And that's the way you'd be able to tell. Maybe just to talk briefly about pain, because quite a number of people sort of ask, I'm having, or come in to see us and they're saying, listen, I'm having breast pain, could it be a cancer? Now, pain is not a typical sign of breast cancer, right? And because of the hormonal fluctuations, I would say anywhere between 70 to 80% of women at some point in their lives are going to have breast pain. That's how common it is. But so breast pain on its own is not necessarily a sign of anything worrisome, but of course if it's persistent, if it's intractable, it would still get it would still warrant you seeing a physician. But pain on its own is not necessarily a typical sign of cancer. And I'm reiterating that because people have lumps that are not painful and they say, it doesn't hurt, so it can't be anything. No. Usually the most common presentation is a painless breast lump. And so it's important not to associate pain with anything sinister, but also not to dismiss something because it's not painful. Yeah.
Okay, earlier on you had mentioned of many patients asking, why me, how did this come about? Let us look at the risk factors of breast cancer.
So in terms of the risk factors, I mean, one would say there are risks that we try and divide them into what we call modifiable versus non-modifiable risks. Now, non-modifiable risks are the stuff we can't do anything about, right? We can't change the fact that we're female, which automatically increases your risk of getting breast cancer. The fact that you're female automatically is in itself a risk factor. We can't change the fact that we're getting older because automatically age as well is a major factor in increasing the risk of breast cancer, because the older you get, we've talked about the abnormal cells, the more you're likely to have your systems less efficient at clearing these abnormal cells. And so those are and then you can't necessarily change your family history because some people come in because maybe they had an aunt or their mom had cancer, or maybe somebody in the family had a cancer and they want to know, am I at risk as well? And I think it's important to note that if you look at breast cancers, only 10% of breast cancers are what you call have a genetic basis.
Now let us look at the treatment. How does the treatment look like once someone is diagnosed of breast cancer?
Okay, so usually the first steps, I would say, even before we get to treatment, is a diagnosis. And I think it's important just to talk a little about that, because we find quite a bit of concerns and, unfortunately, misinformation around the diagnosis. So usually when you go to the clinician, one needs to have what we call a triple assessment, meaning that we do a clinical exam and we confirm, yes, there's a lump. We then go ahead and do some form of imaging. Usually if you're above 40, we will do an X-ray, mammogram of the breast, which is basically an X-ray of the breast. And then we will then do what we call a biopsy, meaning we'll usually take a needle, do what we call a core biopsy, take a small amount of tissue from the lump, have it taken to the lab, and then they'll be able to confirm the diagnosis. Once that is done, and the reason I'm emphasizing this is because we have quite a number of people who come in with a lump and go see a clinician, and no imaging done, no biopsy done. They're just taken to theater and somebody cuts out something and it comes back as a cancer, and that's not appropriate, because the surgery that you do for a regular lump is very different from the surgery that you do for a suspicious lump, and is very different for the surgery that you do for a cancer. And so we say nobody should be taking you to theater to find out what it is. You should already know what you're going in to do, right? So imagine this lady has gone into surgery, has had a lump that's saying it's cancer. Now we have to take her back to theater for a second surgery to now either remove the entire breast, which she probably maybe didn't need to lose in the first place, depending on the size of the tumor. So it's very important that the correct steps are followed. Otherwise, then that can sometimes cause additional costs, additional anxiety. And then once you've had your diagnosis, the next thing you hear is staging, because usually the next question people want to ask is, what is the stage of my cancer? And so even before treatment, we need to know. It's like any journey, Ida. If you're going on a journey, you need to know, okay, where am I heading? What do I need to pack? What am I wearing? Right? And so part of that, knowing what to prepare for the journey is the staging. And staging involves, so the common areas that the breast cancers would typically spread to. The first area is the glands under the arm. And that's why we say, even when you're checking the first sign, sometimes it's important to also check, under the arms, in the armpit area, because sometimes you may not necessarily feel a lump in your breast, but sometimes the first presentation may actually just be, a lump under your arm. And so in terms of staging, the other areas that breast cancers would typically spread to is the chest, the abdomen, mainly the liver, and the bones. And so we do a couple of tests to see if there's any evidence of cancer in these areas. Depending on how small the tumor is and whether or not the glands are involved, we may do some other tests like CT scans of the chest and the abdomen. Not everyone needs a CT scan, especially if it's a very early cancer. We may just end up doing a chest X-ray and an abdominal ultrasound, but you do need to have that staging, right? And then once you're done with the staging, even before you start treatment, you need to have what we call a multidisciplinary team discussion, right? Because if you think about the treatments, there are all these different aspects of treatment. We've talked about surgery, there's chemotherapy, which is basically the medication that you're getting through the veins. You could potentially have, you may require hormonal therapy, which would be a tablet for a couple of years. Or you may require radiotherapy, which is, again, a special dedicated type of X-ray, which is used in the treatments. And then The other thing is that when you say breast cancers, Ida, it's almost like saying painkillers, right? There are very many types of breast cancers and they all behave slightly differently. So knowing what type of breast cancer you have is also important. And so usually the first thing as part of the confirming the diagnosis is, yes, confirming, yes, it is a breast cancer, but confirming what type of breast cancer it is, because that has implications on the treatment. And so we've gotten this diagnosis, yes, we've confirmed what type of cancer it is, then we say what stage it's at, right? The next thing, as I said, is now having that multidisciplinary team, because then you have the surgeon, you have the radiation oncologist, you have the medical oncologist, and we're all sitting together with the pathologist, who's the one who confirms the diagnosis, and with the radiologist, who's the one who checks, for areas of spread of the cancer. And we all sit down together and say, what is the best treatment plan for Jane? Because exact same tumor, similar circumstances, treatment for Jane may be very different from treatment for Mary. And it's important to, and then I think what had traditionally happened, unfortunately, I would say in some parts of the country, is you got the treatment depending on who you saw first, right? So if you saw the medical oncologist, you would maybe get chemotherapy. If you saw the surgeon, they would operate, and that wasn't necessarily the right decision. And so anywhere else in the world, and this is what we've been trying to build up nationally as well, and even as part of the recommendations and the guidelines, is that there needs to be that multidisciplinary discussion. Once we've sat down as a group and decided on the treatment plan, and because we're all each other's checks and balances with the patient always at the center, because we're looking at what is the best thing for this patient, given their unique circumstances, given their other social factors, what is the best treatment option? And we try and customize that. And then we get to the treatments. The treatments, as I said, are, as you notice, they're all these different facets. And I would say surgery is, depending on the type of the type or stage of cancer that you have, we may, for early cancers, the first line of treatment is usually surgery. And surgery could be either what we call breast conservation therapy, meaning we just remove the lump itself, or it could be what we call a mastectomy, meaning we remove the entire breast. And then once that is done, you may, depending on the type of tumor that you have, require to be on a tablet for anywhere for 5 to 10 years, depending on the risk. But that's an overview of, this is now we're talking about curative cancers, which is where we talked a little about the stage. We typically tend to have, one would say, stage 1, stage 2, stage 3, stage 4. Stage 4 are what we call, stage 1 is a very early cancer confined to the breast. Stage 2 and stage 3 are small lumps confined to the breast or the glands under the arm, but have not gone beyond that area, and depending on the size, it could be the B stage 1 or stage 2. Now, stage 4 is what you call metastatic, meaning it's already gone beyond both the glands under the arm and the breast. So it may be in the lungs, it could be in the liver, it could be in the bones, and so in those kind of patients, the different treatment options like surgery. Surgery is mainly just for the local control, to control the disease locally. And so if the disease has already gone beyond, then there's probably a limited role for surgery. And so in these patients who have more advanced cancers, you may find that the mainstay of treatment is with the medical oncologist. We're giving you either chemotherapy, some tablets depending on the type of cancer that you have. And that's why I'm saying it's very complex. So it's not enough to just have one person. It's important to have that team approach to treatment that actually helps to sort of, give the best outcomes for patients.
Thank you very much. It's very critical information that you've shared. Maybe as we wind up, you have any words for our audience, any last words, any takeaways?
Yeah. I would say It's important to take, well, two things, if with your permission. I would say the two thoughts that I would say is it's important to take charge of your own health. I mean, we've talked briefly about, going for screening, and people wonder how, should I do it? Ideally, we usually say you want to come in, if we look at the national sort of guidelines, they recommend at least from the age of 25 to 40 at least, going to see a clinician, which could be any health worker, your nurse or whatever, and having a clinical breast exam at least every 1 to 3 years. And then once you get to 40, it's important to, in addition to the clinical breast exam, to come in once a year and have a mammogram done, which is an x-ray of the breast, and that's all the way up to about 55. And that's the reason they've structured it that way is because the average age of our patients, we get our patients diagnosed, that is about 48. So all the way to 55, from 40 to 55, come in once a year, have a clinical breast exam, have a mammogram. And then once you get to above 55, within the 55 to 75, ideally it's, you should have a clinical breast exam once a year and then a mammogram every 2 years. Now, I always say from 1 year to the next, the best guide of what's going on with Mary is obviously Mary, right? So Mary needs to be aware of what's going on rather than coming a year later for me to tell her, oh, by the way, did you know, this kind of thing. So we need to take charge. And sometimes we also need to think about, somebody joked and said, if you drive, we sometimes treat our cars better than we treat ourselves. Right? Because every couple of miles you send it to the garage, right? You don't wait for it to break down. But with our bodies, you wait for the car to break down, as it were, then you say, okay, let me go to the hospital. So we're saying if we're able to take ownership over our health, take charge, don't ignore stuff, learn about the signs and symptoms, talk to a health worker, empower yourself, because really we're partners in your health, right? But you should be the primary driver of your health. And so that is the message, the key message that I would like to share with the public. The other thing is that cancer is not a death sentence, right? The thing is, as I said, with the advances we've made in terms of therapy and treatment, there is always treatment. Now, the treatment goals, as I mentioned earlier, might change, but there is always hope. There is always care that you can receive, and so don't feel that this is the end of things. It is probably the start of many other things, but do get checked, do get the appropriate tests done, do have a multidisciplinary discussion, and do let us help you, in your cancer journey. The other thing that I would say, sorry, I know you asked for a couple of things in passing, is for me it's critical because I feel that it's important for us to provide mental support for our patients, and I feel that there's still a lot of stigma around not just mental health and the cancer diagnosis. And so what we tell our patients is you don't feel that you have to struggle. Now, what tends to happen with any diagnosis is like the stages of grief, Ida. And people are asking themselves these questions, like, you sometimes go through anger, you're like, why me? I go to the gym every day, I'm, working out, I'm eating healthy, why has it happened to me? And sometimes you get into denial, you're like, no, I'm not, going to, why am I, you don't actually want to process what's going on, and sometimes you get into bargaining, telling yourself, if I do this, will this happen, that kind of thing, and then you gradually work your way through to acceptance. But it's not a straight curve, and you're consistently going back and forth between these options. And sometimes what I've realized is, especially amongst women, ladies feel the need to be strong for the entire family, and so sometimes you don't have the space where you're able to feel like this is huge, this is intense, this is what I'm feeling. And so counseling and support is a critical part of the cancer journey. And sometimes when I suggest it to ladies who come to see us, they're like, no, I don't need that. Why are you talking about, psychologist or whatever? But we're like, no, it's a strength sometimes to recognize when you're struggling, right? And the system and whatever's are in place to support you. So I think just as a community, we need to look at how do we support our patients better. We do have sort of peer-to-peer cancer support groups that are incredibly helpful, but I think a lot of conversations and conversations in these spaces need to be had, one around the psychological support for patients, and two, access, because even as we talk, we just didn't talk about it, we brushed through it, but quite a number of challenges still exist around barriers to access, and that's contributing to why our patients get diagnosed late. Yes, there are financial barriers. Yes, there are systems barriers, but there are also social cultural barriers that all impact patients. So I think we need to have discussions around, why, I have a cancer, why am I not able to access care? What can we as a broader community do in terms of advocacy to improve access for everyone? Again, quite a bit of psychosocial and psychological support comes with breast, for instance, reconstruction. Sometimes patients don't want to come in because they're afraid of losing their breasts. And what has traditionally been the norm is that they wouldn't get any support for their reconstructive surgery because maybe the care providers consider it cosmetic. And we're saying that breast cancer surgery, for instance, has the highest psychological fallout. And so just being able to successfully reintegrate these patients into, restore them back to the dignity and health, and, their mental wellness is, I guess, a huge part of the treatment. And it is a standard of care anywhere else in the world. And so, I know the narrative is slowly changing and care providers are starting to see that. But I think if we push as a community, just for all our men and women affected by breast cancer, to have support at all levels of their care, whether it's their diagnosis, whether it's their treatment, whether it's their further survivorship and reintegration back into the community, those are the discussions that we really need to have.
Thank you very much, Dr. Ari, for your time, and thank you for sharing that very critical information tonight on Health Nuggets.
Thank you. Thank you so much for having me.
Santi. Well, that was Dr. Miriam Mutebi, a breast cancer surgeon. And just to echo some of her words is that be in charge of your health. And as far as breast cancer is concerned, look, move, and feel. In short, be aware of your breast area. My name is Aida Munzati, and that's all we had for you from Health Nuggets. As always, your health matters.